Today's presenter is Dr. Prasad Kilaru. He is certified by the American Board of Plastic Surgery and the American Board of Surgery.
Hi, thank you all for coming in on a Saturday, and thank you Vicki and Laura and Lucy for putting up this great program. And it's nice to see a lot of familiar faces here as well. A little different topic than the first two that we had talked about, scary stuff, heart, brain. I figured we'd keep it a little bit lighter. So we wanted to talk about plastic surgery, cosmetic surgery. A lot of people combine both of those, feel that plastic surgery is cosmetic surgery. It's actually a little bit more than that. So plastic surgery by definition is something that we use to, or it's a field that involves reconstruction of different parts of the body. That's one of the things I like about it, head to toe, pretty much anywhere, whether it's related to birth defects, trauma, cancer, burns, any of those things, we help in reconstructing that. A portion of plastic surgery, usually 10 to 15% of most plastic surgeons' practice, is cosmetic surgery, where we're using those same techniques to improve the appearance of a person, whether it's in the face or nose or breast or other body parts. So cosmetic surgery, we're working on somebody or working on normal structures, trying to make them look better, feel better. Reconstructive surgery, we're working on abnormal structures that have become abnormal because of, again, trauma, infection, cancer, any of those things. We're also obviously trying to make the appearance better as well. As far as the cosmetic surgery goes, depending on which body part bothers you, we can address the face, the eyes, the brow, the breast, the belly, again, pretty much any part of the body that has issues. What we found is a lot of times we see changes occur after pregnancy, after weight gain, weight loss, or specific treatments, especially cancer treatments, and I'll go over some of the things that we as plastic surgeons have to offer for those situations. Plastic surgery, as Dr. Liepar said, I'm a board-certified plastic surgeon, and plastic surgery training is quite intensive. After med school, it's anywhere from 6 to 9 years. And those of us that are board certified go through a written and oral examination and are usually members of the Plastic Surgery Society. There are other surgeons that also do cosmetic surgery, ear, nose, and throat doctors, dermatologists, OBGYNs. I'm a little bit biased because I feel that the training is a little bit different. The Plastic Surgery Society put out this huge advertising campaign saying, make sure your surgeon's board certified. So there's this board that came up called the American Board of Cosmetic Surgery, which is not an accredited board, but then the physicians can say we're board certified with that, but the boards you want to look for is the American Board of Plastic Surgery. Where we do the surgeries also varies. A lot of the simpler procedures we can do in the office. Anything that's a little bit more involved, we prefer to do at either a surgery center or a hospital. That allows us to provide general anesthesia for the patient, better monitoring. We have anesthesiologists there that help with that process as well. And in the outpatient surgery center, we can do the day surgeries or the overnight stay surgeries. Anything that's a little bit more involved, we end up doing in the hospital. But as you can imagine, hospitals tend to be a lot more expensive, so we try to avoid doing cosmetic surgery in the hospital setting. So what's the reason people have cosmetic surgery? The wrong reason is to do it for somebody else. And that's one of the red flags when we come in. The reason that most patients that come in to do it is they want to change something about themselves that's been bothering them for a long time, or they've had a significant change in their life, significant weight loss, or after pregnancy and childbirth, how their body looks has changed, and they want to kind of bring back how they looked previously. In certain situations, it may also be to help with specific symptoms that they have, especially in patients who've had breast cancer or in women who have very large breasts. And I'll show you some examples of breast reduction and how that can really affect how you are able to do things in life. And for every age group, there's a different set of surgeries. Just concentrating on the body and breast, and the early ages, it's usually breast augmentation or liposuction. Later on, abdominoplasties and breast reduction surgery or breast lift surgeries and other set of surgeries that are pretty common. Just looking at the statistics, almost 1.8 million different kinds of surgical procedures were done. This is last year in 2017. The most common is Breast augmentation, about 300,000, and liposuction is the second most common, about 250,000. Just to kind of give you a perspective, there were about 160,000 cardiac bypass surgeries done last year. So as far as the number goes, it's pretty popular surgeries across the board. After pregnancy or significant weight loss, the changes that we see are weight gain or weight loss, changes in the breast shape or size, the abdominal shape. You also see involution of the breast and abnormal weight distribution. So what we try to do, again, depending on what's bothering you, is correct those symptomatologies. And specifically with the breast, change in shape or size, change in the amount of droop, ptosis is the medical term for it in the breast. And I wanted to talk briefly about breasts and augmentations, lifts, reductions, and how we treat cancer, so I'll just go through those. Breast augmentation is the most common cosmetic surgery that we do, as I mentioned. We use an implant, either a saline or silicone implant. We put that either above or below the muscle, and that improves the shape of the breast, but it also can improve the contour of the breast. It's usually done as an outpatient surgery, about 1 to 2 hours. We can do it with either general anesthesia or local anesthesia. I prefer general anesthesia, I think it's safer. Recovery is pretty short, usually about 1 or 2 weeks. And if we put it under the muscle, it's a little bit more painful, but in my mind, it's a lot safer. Patients who are good candidates are, again, somebody who's mature, motivated for the right reasons. There have actually been several studies that showed that the self-confidence in these women improves, that they have a very high level of satisfaction with these operations. I've been doing this for 20 years. I've yet to have somebody come back and say, I wish I didn't do it. The key is, from my standpoint, is to make sure that the patient coming in is coming in for the right reasons and that their expectations are realistic. And when that's the case, usually we're able to please them. For the incisions, typically 3 locations, either in the armpit, around the nipple, or under the breast. When we first started training, we used to do most of the incisions around the nipple. Nowadays, we do most of the incisions underneath the breast. And again, for the position of the implant, this muscle here is the pectoralis muscle. We can either put the implant under the muscle or over the muscle. Again, when we first started training, over the muscle was popular. Nowadays, we found that under the muscle is better and safer for the patients. Complications are pretty rare. Main complications, hematoma, which is basically a bleeding that forms a blood pocket, infection, changes in sensation, capsular contracture, which is scarring around the implant. Whenever you put an implant inside a person, whether it's a pacemaker, a breast implant, or IV catheter, the body forms a scar around it. And that scar is called a capsule, and occasionally that capsule can tighten or contract, and that's called capsular contracture. And that's relatively common complication that we see. Maybe 1 in 50, 1 in 100 patients can have some degree of that. Breast lift is something that we do in patients where there is sagging of the breast, again, usually because of pregnancy and breastfeeding or because of significant weight loss. Again, as I mentioned, we like fancy words. We also like to classify everything. So depending on the extent of droop, we give it a grade 1 or grade 2 or grade 3 and things like that. But it also helps us in planning as far as how to treat the degree of droop, depending on how much it is. So with the Mastopexy, we lift the breast. We also reposition the nipple and areola so that it's in the proper position. We try not to remove any breast tissue, and sometimes if the patient desires, we can also increase the volume by putting an implant at the same time as the lift. As I mentioned, depending on the degree of the droop, grade 1 or grade 2, we have different incisions that we make to be able to take out some or more skin to get the result that we want. So this is somebody that potentially has more droop, so we can take out a lot of skin in the different areas, and then when we bring it back together, better shape and position of the nipple areola complex. Similar with the breast augmentation, similar complications, asymmetry, hematoma infection, changes in the sensation and such. Again, these are all common complications, but they're relatively rare. Breast reduction surgery is something that we do for both cosmetic purposes and also to treat a medical problem. So in women who have large breasts, there are a lot of symptoms that can occur, the most common of which is back pain, shoulder pain, bra strap grooving, and irritation. You can also have a limitation of activity, and I've seen patients that have had arthritic changes in their neck, upper back, and neck area as well, just from having heavy breasts. And again, because of these medical issues, this is something that more often than not is covered by insurance. Even though it is covered by insurance, we are doing an aesthetic operation in that we're trying to maintain the shape of the breast, we're trying to bring it into a more natural position. And we have discussions as far as making sure that both the patient and I are on the same page as far as how large or how small they want to be at the end of the operation. There are different techniques that we use. Again, our main goal is not only to reduce the breast, but to maintain the blood supply and the nerve supply to the nipple in place so that we're still going to have a functional breast. And this is just an example. Depending on where the excess breast tissue is, we can keep the blood supply to the nipple coming from above, from the side, from below. This coming from below is the most common. It's called an inferior pedicle technique. And that's the most common technique that we use to do the reduction. And again, just like with the breast lift, all of this tissue here with a breast lift, we're just taking the skin out and kind of pulling the breast tissue up. With the reduction, we're actually cutting all of this breast tissue out and then moving the nipple up so that once it's done, we're closing this part together and you have a very similar appearance to what a breast lift looks like. Complications, again, very similar. And we've taken large amounts out. I've had patients that have taken 2 or 3 pounds per side out, and you can make a huge difference in their daily life by essentially removing a big bell around their neck. Moving on to abdominoplasties. This is basically the medical term for a tummy tuck. We're going to use this procedure to get rid of the extra skin that's present, again, after childbirth, after weight gain or weight loss. We try to keep the incisions low so that they're hidden well. So this is just an example. Here's the abdominal tissue. We make the incision down here. And through that incision, we open up all of this area. With pregnancy, as the baby's growing, the skin stretches, but the 2 muscles here, which are called the rectus abdominis muscle, that's what gives people the six-pack that you see in the gym or on the beach. So with pregnancy, these get separated out. So there's a gap between the 2 muscles. So what we do is we then, at the time of the tummy tuck, we then tighten these muscles back up. We put stitches in and tighten the muscles back up. So that cinches the waist. So it kind of recreates the shape of the abdomen that was there before pregnancy. And then we pull down the extra skin. So this is the hole where the belly button was. We make a new belly button and we kind of get rid of all of the skin. So pretty much all the skin that was present from the belly button down to the hairline, we get rid of, and this skin that's up here, we pull down and make a new opening for it. And I'll show some pictures of that after. And we do this as a solo procedure, or we can combine it with other procedures like a hernia repair or a hysterectomy, or with other cosmetic procedures such as liposuction or breast surgery or what have you. And as I was saying, any skin tags, scars, stretch marks, all of those we remove, anything that's below the belly button. A lot of times we do combine liposuction with the operation, and in a lot, whether it's a breast reduction surgery or the abdominoplasty surgery, I usually do some liposuction just to kind of feather or even out the contours around the edges to make things look more normal. The muscle tightening we already talked about. Almost for any surgery, smoking's bad. And we always tell our patients we'd like them to quit smoking. But for the abdominoplasty, because we are elevating it and I'm relying on blood supply from a little bit further away and we're pulling things under tension, I usually tell my patients they have to stop smoking for at least 3 or 4 weeks before the surgery. And the abdominoplasty surgery, again, because we're tightening the muscle, the recovery is a little bit longer than the recovery for most of the other surgeries. So typically it's about 4 to 6 weeks before they're able to get back to doing everything, because the muscle tightening does hurt a little bit more than just lifting the muscle up or doing liposuction or things like that. Complications, again, very similar. Hematoma, seroma, changes in sensation, the skin slough that can happen. So suction-assisted lipectomy, again, fancy way to say liposuction. Second most common cosmetic surgery that we see. The way that we do the surgery is we make a bunch of small incisions in the area that we're trying to treat. We pass a metal cannula in, and we essentially suck out the fat through a big vacuum machine. There are different techniques that we use depending on how much fluid we put in versus how much we remove. Fat anywhere in the body, by the time you're about 5 years old, it's distributed, and those fat cells get bigger or smaller with weight gain or weight loss. The distribution is hereditary, and it's also dependent on sex. So women tend to have more distribution around the thighs, lower abdomen. Men tend to have distribution around the abdomen, the beer gut, so to speak, and over the chest area as well. With liposuction, one of the things I always tell my patients is we're not changing your metabolism. We're not changing your ability to gain or lose weight. So if you eat and don't exercise after liposuction, you're going to gain the weight back. What liposuction does is by physically removing the fat cells, you're less likely to gain the weight back in the same area as you had before. Doesn't mean that suddenly your arm's going to become huge. It just distributes out evenly across the rest of your body. So ideally, liposuction is good for somebody who's in reasonable shape but have a few areas that are problematic. Saddlebag areas or love handle areas, otherwise in good shape. Now we can do it, but it doesn't work as well just to kind of get rid of the fat, because even if you get rid of the fat, if you're not maintaining it, it's going to come back pretty quickly. Lots of studies have shown that you really don't want to take out more than about 10 pounds, about 5 liters in one sitting. Usually we do about 2 or 3 pounds in one sitting when we're doing liposuction. So again, if you're not monitoring your diet and exercise, 2 or 3 pounds, it's very easy to put that back on if you're not careful. So as I was mentioning, so we make a little cut, and then we put this metal cannula that's connected to a big suction. Then we kind of treat the area till we get to the contour that we need to be. For any given area, we usually try to go in a couple of different directions so that we are addressing it in different directions. So you're breaking up the fat and removing as much of the fat as you can. So you're not having what I call cornrows, just having one hole and going through one hole and missing areas that you otherwise wouldn't miss if you're going through a couple of different holes. But these are very tiny holes. Each of them are less than a 1/4 inch. And what we try to do is keep them in the normal skin creases. So once they heal, you're really not going to be able to see them. Complications again, hematoma, seroma, etc. Death is one scary complication that can happen with liposuction. If you have people who don't know what they're doing, or if you have people that are very aggressive, because there are important structures inside the abdomen. And if you have somebody who's not careful, is a little too aggressive, then you can injure the kidney, liver, spleen. Or if you're too aggressive, you take too much fat out, well, you're taking fluid and blood out with that also. So there's a possibility that if you take too much out, the patient can go into shock and such. So that's why it's important that you go to somebody who knows what they're doing and knows the limitations. Switching gears, talking about breast cancer. I have a whole 1-hour talk just on breast cancer, but just to give you an overview, when we're looking at surgical options for breast cancer, the 2 options are lumpectomy with radiation therapy or mastectomy. There are different levels of mastectomy depending on how much skin and what other structures are being removed, which is determined by the extent of the cancer, how invasive it is, how aggressive it is, and such. When we're looking at reconstruction, after a lumpectomy, we either address the affected breast or we address the opposite breast to try to get symmetry between the 2 sides. And more often than not, we end up doing something for both breasts to, again, try to get them to be more even. And then with reconstruction, after mastectomy, we're reconstructing the entire breast. So we want to be able to bring something back together that looks like a breast. So I tell my patients with breast reconstruction for a mastectomy, it's hard to hit a home run with one operation. So we hit a bunch of singles. So the first operation is to make a breast mount, make something that looks like a breast where the breast should be. The second operation or second stage is to get symmetry between the 2 breasts. Third stage is to make a nipple. Fourth stage is to tattoo the nipple to match the opposite side. Now, all of these stages are covered by insurance. And I have patients who do one operation and say, hey, in a bra, I'm fine. Nobody sees it. That's all I need. And I have other patients that want 3, 4, 5 operations. Still, they're happy that both sides look alike. The 3 common ways in which we do the breast reconstruction is to use implants or to use your own tissue. When we're using implants, the implant doesn't provide a lot of extra volume, so we do what's called tissue expansion. We put essentially a plastic empty balloon underneath the chest, underneath the skin and muscle, and we slowly expand it over a course of several weeks, and we stretch the skin as we're doing that. Just like when the baby's growing when you're pregnant, that stretches the skin in the abdomen. The tissue expander stretches the skin on the chest, and once we've got adequate skin, then we put a permanent implant in to provide the shape that we have, or that we need. We can also use your own tissue, and there are kind of two ways of doing that. One is to use tissue from the back along with some muscle. Unfortunately, most people don't have enough skin and fat in their back to make a full breast, so we usually end up still having to use an implant, albeit a smaller implant, so it's not that popular a method of doing it. We use this more as a salvage. We've tried something, it didn't work, we need to do something to protect that area, things like that. The method that we use more commonly if you're using your own tissue is what's called the abdominal tissue flap, and we take the tissue from the lower abdomen and use that to make a breast. And most people have enough tissue in their lower abdomen to make a full breast. So that's our preferred method if we're not using implants. So in summary, there's a lot that we can do from a cosmetic standpoint. My goal is always to make sure that we understand what the patient's concerns are, what the likes and dislikes are, and be careful. Right? And in my mind, what I tell my patients is we're taking a healthy person and making them ill, at least for a short period of time. Unlike reconstructive surgery or any of the other problems. So we want to make sure that we are as cautious as we can. That's why I keep putting up the complications slide up for each procedure, because we want to make sure that they understand what the potential risks are. Multiple procedures can be done at the same time, whether it's associated with reconstructive procedures or other cosmetic procedures. Most of the time the recovery is relatively quick. It's, like I said, 1 to 2 weeks for most of the procedures we talked about, except for the abdominoplasty where it's a little bit longer. The biggest change that most people have noticed with cosmetic surgery is an increase in their self-image and confidence. And that's why I went back to, it's not for anybody else that you're doing this. This is an area that's bugging you. This is a problem that you'd like to have fixed, and that's why to do it, right? And I can't tell you a number of patients that come back and say, whether it's after breast surgery or after abdominal surgery, that their clothes fit better, or they feel better about themselves and whatnot. But you can also go overboard. So we don't want to be doing too much, right? Thank you.